Okay, thank you everyone for joining this morning/afternoon. If you haven't had a chance already, please go ahead and introduce yourself in the chat with your name, practice name, and how you found out about this program. We're so excited to have you with us today. Today's training is led by Dr. Joel Davidson with the Ohio AAP. If you could advance to the next slide, please. This is just our CME disclosure. Dr. Davidson, faculty of this educational activity, has no relevant financial relationships with ineligible companies to disclose. Our work is funded by the Ohio Department of Health, which leads us to this disclaimer. The views and opinions expressed in this presentation are those of the authors and do not necessarily represent official policy or position of the Ohio Department of Health. I will turn it over to Dr. Joel Davidson. Dr. Joel Davidson is a general pediatrician and physician leader at Akron Children's Hospital, working with patients and families at the Locust Pediatric Care Group. An Ohio native, he grew up in Columbus, Ohio, and received his undergraduate and medical degrees from the University of Toledo and completed residency training at Akron Children's Hospital and has been practicing since 2011. He's an associate professor of pediatrics at the Northeast Ohio Medical University. He now serves as the associate director of ambulatory informatics systems, and is the patient-centered medical home director for Akron's network of primary care offices. Dr. Davidson has a special interest in providing screening, diagnosis, and treatment for children who suffer from lead poisoning. Dr. Davidson was recently named the 2023 Arnold Friedman MD FAP Community Pediatrician by the Ohio chapter of the American Academy of Pediatrics. Thank you so much, Dr. Davidson.
Well, thank you very much, Suhavi, for the introduction, and thank you all for thanks to each of the participants for coming, for being interested in having your practice work through the issue around lead and lead poisoning for children, and for your attendance here today. I would like to just start by recognizing a few of my colleagues that have been responsible for some of this material. My kind of co-lead in this work is Rupa Thacker. We'll have her email a little bit later on today from the Cleveland Clinic. Rupa's, along with Nick Newman, have put together a large amount of the materials that we're going to be presenting as a part of this program and talking and introducing today. So the objectives of what we're going to cover in our time are going to be to outline some of the anticipatory guidance around lead poisoning prevention. We're going to talk about the lead screening guidelines in the state of Ohio, and a little bit about testing, how we can compare and contrast some of the different ways that you can collect lead within your office, and then really focus some time on what your involvement and interest in this program is, in identifying some action items that you're going to work with your group on as you move into the next phase of this kind of practice coaching model that we've developed. You go to the next slide for me, Mark. Awesome. So I want to start by kind of just describing the why. First of all of us are here to protect and care for children, and Ohio is actually the third highest percentage of kids, has the third highest percentage in the country of kids that are less than 6 with elevated blood lead levels. So this work is really important in the environment that we're in. And I just want to remind, everyone kind of knows that lead is bad, but the effects are irreversible. And what we're talking about is trying to identify some opportunities within the preventative strategies to mitigate and, first of all, eliminate those exposures so that we don't have this irreversible impact on neurocognitive effects of our kids. 80% of Ohio's lead cases are from deteriorating lead-based paint that are from houses that are before 1978. And that's data coming from the analysis that happens from the Ohio Department of Health. So it's really, I applaud each of you for thinking about this issue of lead and lead poisoning and figuring out how we can best engage with the patients that you care for to make their outcomes the best that they possibly can be. And we have people from all over the state. Today we have 15 different practices that are going through this introductory session. We've had a large number of other practices that participated in a similar session. But in total, there's 52 practices that are engaging with us in this this effort through the Ohio chapter of the American Academy of Pediatrics and our in that partnership that we have with the Ohio Department of Health in this practice coaching model. So congratulations, thank you for your interest, and I know that we're all here for the right reasons. You can go to the next. So there's really kind of three main modes of prevention. There's primary prevention, secondary prevention, and tertiary prevention. Primary prevention is eliminating the exposure of children to lead in the first place. And this can be done through some public approaches with remediation of old contaminated housing stock. But it can also be done in our offices through anticipatory guidance discussions around cleaning, occupational risks and hazards, and other ways that we can have families prevent their child from being exposed to lead in the first place. Secondary prevention is really what we talk about when we talk about screening and testing for lead in our offices and in our clinical care. And that is to identify cases where lead is an issue, where a child has been exposed to lead that has a high lead level, and how we can mitigate and reduce that future harm and future problems with that child, either reducing their exposure to where they're not getting exposed to lead as much and their levels not increasing, or just kind of totally eliminating that exposure. And then the tertiary prevention is really how are we going to make the outcomes for that child as best as possible. And we're going to talk a little bit about some of the opportunities that we have for kids that are identified as being exposed and have a high elevated blood lead level, involvement with early intervention services. And that's an example of a downstream tertiary prevention. So we're going to talk about each one of these, and we're going to start with talking about some anticipatory guidance approaches that you can use in your office, in your clinical care, even in the next couple of days, weeks, and months. We are encouraging every office to focus on discussing anticipatory guidance topics around lead in the 6-month well child check visit. The discussion will focus on common sources, high-risk occupations, things that families can do to improve their hygiene, and also talking about the dietary impacts. For lead, it's specifically diets that are high in iron, calcium, and vitamin C, because those nutrients reduce the risk of exposure to lead. Kids won't seek out lead as much with iron-rich diets if they're not anemic. And it mitigates the risk of further ongoing absorption of that lead when it's in the child's system. Some practices have taken this anticipatory guidance and embedded that into their electronic health record. And what we're showing you here is an example of a way that you can document some of those lead risk factors, that you've discussed them, and what you want to do in terms of a plan. So I want, as you're thinking about some of these anticipatory guidance topics as leaders within your practice and around this topic, I want you to think about what are some ways that you can make this anticipatory guidance a little bit more accessible to the providers in your office, make it easier to talk about those things and document that you have talked about them. So there are some electronic health record interventions that you can consider, but even thinking about what topics that you want to cover at which visits is going to be important going forward. So we've developed a tremendous amount of resources that are designed to help support your conversation with patients around lead. And this is a copy of the RAC cards that many of your offices probably have already received. If you haven't, you will be receiving them soon, and certainly will have that as an option for your coaching visits that are coming up soon. I love these RAC cards because they talk about the topic of lead that sometimes gets overwhelming for families. But these RAC cards do it in a way that's pretty simple and just gives people a good overview. They're a little bit, they're pictorially designed to be simple, but also have some good take-home information. and also allows the QR code allows people to kind of take that information with them. So I just want to review some of the things that are on some of these cards because I think they're really important. Remember, children are the people that are the most at risk of lead, mostly kids that are less than 6 years of age and younger. We, again, start talking about that at the 6-month visit because that's when kids start doing that hand-to-mouth behavior where they're taking lead from their environment and putting it, ingesting it into their bodies. You can also get lead through inhalation, but certainly the oral route is the most common. No lead level is safe. The threshold currently for Ohio is anything less than 3.5 micrograms per deciliter, but no lead level is safe for a child's developing brain. And those impacts really do include learning and behavior as the primary outputs. It's not incredibly obvious when kids are exposed immediately to lead. We usually start seeing the effects of a lead exposure in those early childhood years of the first through third grade. As they enter into school and we start to look at some of their executive functioning deficits. We already talked about the 80% of children, are exposed. Yes, we did already talked about 80% of children being exposed to lead from paint in their homes. And paint and dust is the most common source, but there's other sources such as bare soil, traditional spices or traditional medicines, a traditional makeup, for example, in some populations of our patients. Parents' occupations, including remodeling, construction, firearm use, pottery, lead smelters, or smeltering within a job or an occupation. Lead service lines that lead from the street to the house, from the public to the private, transfer. Old pipes within houses can also be a source, and so that's why water is on that list. But you can also get lead in jewelry, beauty products, certain toys, antiques, those sorts of things. The middle card kind of talks a little bit more about what we can do. So only 40% of high-risk children in Ohio receive a recommended lead test. And that's part of why we're talking about this in the context of practices throughout the state of Ohio, and why we're so excited to have 52 practices participating in this program. Is really to increase their lead screening rates and get more kids tested in that secondary prevention approach. All children living in high-risk zip codes and insured through Medicaid should have a venous or a capillary test. We'll talk a little bit more about testing in Ohio Department of Health recommendations, but that's right there on that rack card. And then things that families can do is do not disturb paint within your house. Think about houses that are built before 1978 when you're doing construction or remodeling, really like pulling out previous layers and surfaces. I like the water droplet here. One, because it reminds families to run water before until it's completely cold. Really 30 seconds to a minute or so. If you live in an older home, that flushes out some of the stagnant water with leaching from some of those pipes. But water is also a significant source of disruption. So if there's a leak in the roof, or the water from the outside doesn't go into the drain pipes in the right way, water disruption in a house can really be the main disruptor of surfaces. And a lot of families have shown me when we've come to talk about lead, examples of that where the ceiling's caving in, or the paint is chipping or peeling along the ceiling. Families really can take a proactive approach to reduction of lead exposure through cleaning regularly with a soapy, wet rag. Those can be countertops, those can be windowsills, those can be wet mopping on a floor on the regular, meaning like really once or twice a week. And then talking about removing shoes from the shoes from after you come in from playing outside, putting those by the back door. A parent that comes home from work, if they're exposed to lead at work, reducing that exposure by changing their clothes and washing their clothes immediately. And then the last thing on the right side is children, kind of reminding families that kids that have a detectable lead level do need follow-up. They need to monitor for behavior and learning problems. You need to make sure that their diet's rich in the calcium, vitamin D, and iron, and that they are eligible for early intervention services. We've put the number for the state Children's Health Insurance Program on the card so that families can call to make sure that they can get that lead addressed if we do identify that as a source. So Mark, you can go to the next slide. Again, each of you will be receiving the rack cards. The other really awesome resource that has been developed as a result of this program is a little board book. And the Thanks for Keeping Me Lead-Free board book. And again, that was written by Nick Newman and Rupa Thacker and illustrated, and Alexandra Miller, let me not forget her, and illustrated by Jenny Campbell. A very illustrative board book that kids can flip through, but that you can kind of talk to, talking points about diet and about potential sources of exposure. And this book is specifically, they went through this, we've gone through this book and made sure that there's a lot of different representations of different cultures and different cultural practices, and really weaves nicely in a lot of the concepts, and should be a great thing to start that conversation. We're hoping that we want you to give this book out when you talk at the 6-month visit with the kids that age, to start to talk about what are the sources of lead. Let's do that primary prevention from 6 months to 1 year. And then we'll talk a little bit more about testing specifically in your offices at the 12-month and 24-month checkups, and designing a system of thinking about the kids that you're missing that may come late for their checkups, even up through 6 years of age. So the board book's awesome. And again, if you haven't received those, you'll be receiving those in your offices soon to talk about with your coach visits. So let's talk a little bit about screening and testing guidelines. The Ohio Department of Health puts out a good list of questions to think about, and some rules. Honestly, this is written into the state law about who we should be testing in our practices. So the first 2 questions are probably the most important questions on this screening. Is the child on Medicaid? They need a lead test at 12 months and 24 months. Does the child live in a high-risk zip code? There are over 500 zip codes in the state of Ohio that are designated as areas where children are at higher risk of being exposed because of the age of the homes and the burden of lead in those homes. So if that child lives in a high-risk zip code, they also need tested. And that does not include that does not exclude people who have been who live in houses that are built after 1978. So for example, I might have a physician colleague of mine that has children, and they say, if my house was built in 2010, do I need a lead test? And I look at the list and the high-risk zip code is there. I say, actually, you do need tested, and we should take a look at your child's lead test. There's a couple of reasons for that, and most of it is because kids don't always spend time in just one place. And so if children spend time in places other than their primary home, we need to think about those environments as potential exposures as well. So does the child live in or regularly visit? That's the part of that third statement, in a home, childcare facility, or school that's built before 1950. If they do, they need a lead test. Does the child live in a home or school or childcare facility that's built before 1978 that has visible deteriorating paint on the walls? If the answer is yes, then they need a lead test. Does the child regularly live in a home built before 1978 that has ongoing renovations or planned renovations or remodeling? If they do say yes to that question, then yes, they need a lead test. Does a playmate or a sibling have a previous exposure to lead? If that's the case, then we should be watching those kids a little bit closer. Do they come in contact with an adult who is known to participate in a hobby that involves lead exposure? So if they like, I think the best example that I have of that is somebody who likes to a parent who likes to refinish old furniture. They're actively sanding those surfaces down, exposing the previous surfaces within the air. That's a really high risk hobby. Other hobbies that are not on this list include things like fishing and hunting, mostly because those have lead in the materials that are used in those hobbies. Sometimes, like some of the craft hobbies, like leaded windows is a risk for lead, but sometimes it's not, because leaded windows repair is not always involving lead itself. But certainly if you're pulling off a century-old window, the lining of that leaded window certainly does have lead in it. And then the last is, does the child live near an active or former lead smelter, a battery recycling plant, or another industry known to generate lead dust? And families can just really think about what is in your area, and actually look into some of those things themselves. So the Ohio Department of Health has this awesome 8 set of questions. We do encourage you to use these questions in your practice and start thinking about how would you more consistently ask these questions to families, and then make sure that you're following the rules for who needs tested. So we talked about Medicaid and high-risk zip code as being the 2 biggest criteria, and those kids need a lead test at both the 12-month and the 24-month. If they miss that 12-month checkup and come for their 15-month checkup, then they need a lead test for that kind of 12-month time frame. They're going to get tested between 3 and 6 years if they have no previous lead level recorded in your charting, and they're on Medicaid and live in a high-risk zip code. They need a yearly lead test if they answer yes to some of those other questions. So, for example, I have a lead test on a kid at their 12-month and their 24-month visit. They're coming in for their 3-year-old checkup, and they tell me that they live in a house that's built before 1978, that they're actively remodeling. I need to test that kid at that 3-year-old visit. You can do capillary testing, including point of care testing for screening, but for any kid that's over 3.5, you need a venous confirmation. And it's not just an order for that venous confirmation that we're looking for, it's actually going to get that lead result. And the same with capillary testing. It's not. We really want to encourage practices to think about getting that capillary testing result and making sure that that's documented. A lot of our practices order those tests, and whether those tests get done or not, it depends on their process. But a lot of times we're finding that if people really kind of think about and monitor their data, that they're not getting tested in as much frequency in some situations as we might expect. So that's the Ohio Department of Health screening and testing guidelines. Now I want to move into talking about different ways that you can think about at your practice about collecting lead levels. We're, again, now squarely into this testing, secondary prevention. If you already have one of these methods of testing, that's great. If you don't currently have a method of testing, this is going to be a really good, important go-to concept for your group to start to think about what are the different options available to us, and how can we start to get that testing arranged. So the first is the capillary test that you do within the office. The pro here is that it's convenient. The con is that you actually have to be able to do these tests in your office. That takes staff time, and that takes supplies, and you have to know where to send your labs and all of those other pieces. It does require the trip to the lab, or sometimes a capillary test may be done at an outside test that's not immediately done in the office, and that might require that you take that patient to the lab to get the capillary draw completed. It is a good idea to think about, while you're thinking about lead, to also think about what is your practice's approach to screening for hemoglobin, which is also in the recommendations around the 12-month visit, or at the 12-month visit. The second line talks about the LeadCare2 point of care tester. There are some pros with this approach in that you get an immediate result. The cons with that LeadCare2 machine is that there sometimes is a risk of inaccuracy and a recall that says that there's significant risk of falsely elevated low results. And that's the opposite of what we want to do in a screening paradigm. So if we're missing some of those tests that are actually high and the machine is reading them as low, that is something to think about with that approach. The lead care 2 analyzer does have a significant investment of upfront cost and ongoing cost. That's something to consider for your group. The analyzer itself is $4,000. A test kit is $650 for a packet of tests. The labels themselves cost money. And then you're going to need to replenish that printer with ongoing labels that do cost some. And there is some ongoing service charges with that. So if you're not testing, this is an option, and some groups have actually gone towards using this lead care 2. The state Ohio Department of Health has some people that they know are using this system. But if you're thinking about using this system, we want you to investigate all the details around cost. The microtainer is the next collection method. It does come with some cost that's a little less than the analyzer, the lead care 2. The packet of testing is $50 for 100 tests, and you're going to need lancets and Band-Aids to go along with that. The pro of that approach is that it's pretty accurate. And the cons are that it's not as tolerated by patients. The volume of blood that's required is a little bit higher. There is some risk of clotting the tube. It's clotting the tube itself, and they require some refrigeration. So thinking about workflow, where you're going to draw that blood, where is it going to go? Do you have the space? Those are some considerations in the microtainer. The next on our list is filter paper. A lot of groups are excited about this approach, and it is a good, reasonable approach on this list. And there are a couple of different options and companies to work with that provide these kits at no charge. We've heard of some groups throughout the state finding ways to work with other resources within their communities around who's going to be able to process those samples and who's going to be able to give us a result back. You need a minimal amount of blood. Just 2 drops will do. The card, once it's dry, is stable at room temperature. The storage isn't that complicated, and the results are very accurate. One of the problems with filter paper is if the person who draws the child's blood pokes their finger and then smears their finger across the card, that will invalidate the sample. And for groups that want to do some in-house processing of those results instead of sending them out involving a courier and so forth, that does require some specific equipment that you're going to need to think through. Last is the venous test. The venous test is a little bit expensive to the system, meaning the healthcare system. It is very accurate. One advantage of if you go the route of venous testing is that you actually don't need any confirmatory testing. All of the other tests on this chart, if the test came back over 3.5, you would need to get a venous sample. And the reason for that is that all of these tests on the capillary analysis are looking at the surface blood, and sometimes if the child has lead dust on their hands, that can falsely be the reason that the child's lead level is high. That's not actually what the child's brain is seeing, and that's what the venous test is telling us, is what is the central blood sample of the lead. But what's nice about the venous sample, is that you can also run your hemoglobin on the same sample. So again, thinking about your strategy for other tasks within the defined visits is important. The cons, of course, of venous testing is that not every office is able to do a venous draw within their office. It may require the patient to leave your office and go get set up at another lab, which honestly sometimes doesn't happen. And we need to understand that's just how families practice and operate. And then, of course, the pain of the procedure itself is not as well tolerated. All right, so we have a little bit of experience at the Ohio AAP around lead, and in 2020 we set up a lead QI collaborative, and I'm going to share a little bit about that work that we've done in the past and some of the successes and the things that we've learned. And hopefully we'll be able to apply some of the things that we've learned in that previous work to this practice coaching approach that you all are participating in. So we recruited 11 practices based on where they live and based on those practices location throughout the state in high-risk areas and the proportion of patients that are seen by Medicaid in those practices. Our goals of that of the 2020 QI collaborative were to for patients that are attending their 6-month checkup to receive primary prevention anticipatory guidance 90% of the time. For patients that are 12 and 24 months with high risks that had a lead test ordered 90% of the time. And we wanted to improve blood testing completion rates by 25% for patients 12 and 24 months old for their checkups. Can you go to thanks. And what we learned throughout that collaborative was partnering with various entities within your organization is really critical. Integrating the pieces of lead screening into the electronic health record, making things a little bit easier and in front of people within their workflow really does work. So incorporating a reminder, a checkbox, use of standard phrases that are embedded into the record, and building that statement for whether you incorporated the anticipatory guidance at 6 months was helpful. Others found that using health maintenance or a reminder that a task is necessary within the electronic health record when a child is due or overdue for that anticipatory guidance or for the lead testing is a helpful approach. That if you need to change your laboratory approaches for collection methods might be necessary. Myself at our organization, when I first started doing this work in the early teens, 2000s, looked at lead tests. And when I first started talking about this, we had one lead test, and that lead test was for capillary and for venous draws. We now have a separate separate orderable test, one for capillary and one for venous, and that allows for a little bit better data analysis and specificity of knowing which test was from which collection site without having to dig very deeply into lab notes or things like that. The key is that you're going to, for any intervention that you're going to do within your office and or system, is to get buy-in from your stakeholders. That's buy-in from your leadership, buy-in from your colleagues, and buy-in from the rest of your staff, nursing staff, and even maybe buy-in from your scheduling staff around this topic of lead. And so I want you all to consider, as you're thinking about your action items, who all you need to involve on your team to make this work successful. All right, so I wanted to show this slide because it helps us understand what I'm talking about with health maintenance. We can let the computer do a little bit of work to show us what's due. And we are, I don't know, many of us may be familiar with this in terms of immunizations. Your patient's overdue for flu. This is the flag, and this is where to look. But we can also build the electronic health record to help remind us about things like this child needs screened for lead. And there's a lot of sophisticated ways that you can build the electronic health record to support this activity. I know many of you might not have pull in your system, and certainly won't have pull in your system over the next 3 to 4 months that you're going to be involved with this program in deploying those changes within your electronic health record. If you have the ability to do that, go for it, great. But those things, I recognize that those things take time. You have to build in the process, but your action item might be to think about this and put in a request or identify who you'd like to talk to within your system of what might need to happen in order to actuate this kind of a change. But the key here is that you find a way in your system to flag those patients that you really want to intervene on. Okay, so we're going to talk next about getting some buy-in, about making some connection with those stakeholders that you know that you need, Who are those stakeholders? Do you need an introduction for maybe some of those stakeholders? Maybe you don't know the person in your system who deals with labs, or maybe you know the person who who interfaces with the folks from a business level about who picks up your labs, but you don't know what happens after that lab leaves your doorstep. Who do you need to talk to, and how will you engage them, and when will you talk with them? And if you start to actually put answers to paper on this first part, even while you're maybe sitting here listening to me, you can start jotting down like who are my stakeholders, and just put that on the left-hand column. And who can I set up a meeting with, and what will be the content of that meeting? How fast can I start to talk to you about screening? Who all do I need to convince before we have the next meeting, or just that taking the next step? When you're talking to stakeholders, what's important to them? It might be that I'll just share a little bit of a personal example here. When I started talking, I had patients in my practice that had elevated leads. This was before I was really a tertiary lead expert here at Akron Children's, which I do now. I run like a tertiary lead clinic that has lots of multidisciplinary people around development and social work and legal support for kids and medication support for chelation therapy for kids who have really, really high lead levels. That's what I'm doing now. But at the beginning of my journey, I am still a general pediatrician that sees patients very regularly. But at the time, I just had patients that had elevated leads, and I said, how do we deal with this? And like, what's happening? And that's when I started talking to the lab and saying things like, we need 2 tests instead of 1. And when I talk to the lab, what's important to the lab is highly reliable results. And when I talk to my operations people, their motivation was to make sure that it was a highly reliable process that we could efficiently organize into our workflow. I had to look at what current things does our staff have the skill to do. Luckily, what's great in my practice is that people were already able to draw capillary blood levels, but maybe your practice doesn't. So, is it important to your nursing staff that we tackle this problem? You might want to think about what their workflow looks like right now, and what their potential feedback might be, that this is a lot of work, or maybe this is more work for me. How can we rearrange that? Who else on our team could take some of your tasks, and how can we rearrange that, or reprioritize some of the things that we do currently within our workflow? And then as you're thinking about those people and those stakeholders, what aspects of the project can they support? That lab person who really cares about delivering a really good lab result, what matters to them, or maybe they're actually there's something about their work that you could help with. And the example that I have there is maybe something like, our lab was calling every lead level that was over, I think it was 5 at the time. And so they were spending a lot of time on the phone, and we had a conversation about maybe, the 5s to 20s are not as important to call as an emergent lab value. And how you define your emergency lead level within your group can be negotiable. And so we decided that they don't have to call every provider every time, but that providers could see the 5s to 20s and respond to those. But then they got an emergency call when anything was over 20, for example, and that drastically reduced the lab's workload. But finding the right people and making sure that those right people have the right action item is really critical to your action step development. We're going to talk about action steps when the coaches come to your practices and talk specifically about what's happening in your office and what your specific goal is as it relates to participating in this project. So if you're a little overwhelmed by me talking about all the different nuances about change management within lead screening, don't fret. This is just an introduction. I also will say how change management works in my experience is that it's a journey. And so you're starting that journey off with something that's practical and doable, that's able to be accomplished within the time constraints and the resource constraints that you have. But as you enter into that journey, you will identify further action items that may be bigger, that require another, action, another wheel of action. And that's supposed to happen. So kind of expect that you'll end up somewhere where that feels maybe a little bit uncomfortable at first, but if you really break it down, really start to think about what do I need to do and what do I need to do next, that's how you're going to start to make progress in this aspect of addressing and screening kids for lead. I said addressing to harken in and emphasize that primary prevention, anticipatory guidance. I'm talking about this as a topic, and I think you'll know when you've accomplished that, because patients will start to talk about that. They'll say things to you like, I'm thinking about moving, but I know we talked a little bit about lead, and I'm actually looking for a place that's a little bit more lead safe. But I have a question for you about what criteria I should look for. Or in my practice, I started to notice patients themselves were coming back to me and saying, I think my kid needs lead tested today. Sometimes that was actually quite appropriate and correct. And sometimes it was like, well, actually, your kid doesn't need tested because you've already tested them at this age and at this age, and you don't have these risk factors. But here's the things that you can continue to do as you care about that problem. So patients, you'll find that as you talk about any topic more, patients will bring those questions and bring those topics back to you at future visits. Okay, so we've put Mark's email here. Mark Driscoll is the person that many of you have been getting emails from after you've committed to participating in this practice coaching lead, elevated lead level work. My colleague is Rupa Thacker, and you can also ask me any questions that you have along this journey. Both Rupa and I will be taking office hours throughout this program, starting this spring and moving into the summer, where each of us are available for 1 hour in the month to ask anything that you have that your practice coach can't answer, or something that you're working through that's a really more of a technical lead question. We're here to support you. We want you to succeed at this, and we're happy about whatever you uncover. And if you reach a roadblock, we're here to help. So, okay, I thought there was one more slide, and I want to talk a little bit about the Lead-Free Ohio toolkit that's available. You can access the toolkit of materials on this QR code. But as a participant in this program, you have full access to all the materials that our team has developed to help equip you to understand the topic of lead. This material is simplified, but it's also detailed enough where you need it to be. And there's lots about like the sources of lead and the symptoms to look for and what to do when you have a high lead level. And here's things that you can talk to about your family, talk to families about. It's a little bit more centric to providers themselves, that dives into the details that you need to know and the granularity of this topic. So check those tools out. This site, the Lead-Free Ohio Ohio AAP site, is also where you'll go to do some of the work that you'll do before your practice coach comes to do your to submit data for each of the months. And I think I'll have Suhavi or Mark talk a little bit more about some of the specifics with what you need to do with each of those. But all of that information is housed in this Lead-Free Ohio site on the internet, and so it's really good, and it's really accessible, and it'll all be pertinent to your practice's journey on improving improving your lead testing and your approach to lead.
Thank you so much, Dr. Davidson, for such a great presentation. We're going to take a few moments to fill out a quick little form. I'm going to put it in the chat now. So if I could please draw your attention to the chat, we'll take 5 minutes to complete the linked form. This form will be sent back to you as an intent to change letter, and your practice coach will review it before your coaching session to better inform the visit. Please be honest with your answers, as we are using these to support our baseline data and to enhance the quality of your in-office session. So if we could just take about 3 to 5 minutes to complete that form. It's just 3 short questions about what you think you're doing well, where you want to improve, and what your overall goal is for the program. That would be great. Thank you so much, everybody. We'll come back in about 5 minutes at 12:52:53. Thank you. All right, we'll give it about 30 more seconds to finish up your form. All right, we are now going to move into our Q&A session with Dr. Davidson. We do have one question in the chat from Katie Crowell. She said, "We have looked at the lead care too, but the cost is a little frightening considering the sometimes inaccurate results. Do you have information on the microtainer option?"
Thanks, Katie, for your question. I am going to take that specific question back, and I will get some more information to you. There's a couple reasons for that. One, I don't use the microtainer option myself, and I'm not the expert in that, and I want to get you the right materials. And two, I think that this is a good thing to take back into our into the practice coaching session portion of the program. So we can get you some more information. Can you just make sure that you put in the chat where you're from?
Katie, you're from Ottawa County, right? Perfect. Thank you so much. We'll be in touch with some more information and pass that question along to your practice coach. Our next question is from Kyle Mudd, who said, "Question regarding the screening questions. Why is there a difference between 1978 and 1950? Why not all homes built before 1978?
All right. So, Mark, can you go to the slide with the screening questions, please? Great question. So, thanks, Kyle. I think you're a very astute reader. Why do we have to think about like this 1950, 1978 between number 3 and number 4? Personally, when I'm talking to families, I just keep it simple and talk about 1978 for exactly what you're talking about. And I also don't know the historical underpinnings of the questions that were developed that the ODH has published in terms of their ODH, the screening guidelines. So that's the first caveat to my answer. However, I will tell you, houses that are built before 1950 have a greater risk of lead exposure because there was a little bit more effort. So the trick about 1978 is that even before 1978, there were some changes in manufacturing, and inclusion of lead into materials because that was a known issue and or a developing issue. Whereas 1978 is really all paint that was put into homes and residential places was regulated to be stopped by 1978. And yeah, it just probably, and also because of varying, thanks to Javi for adding that in. Just the paint itself had a higher concentration of lead in it. So I think we're starting to notice, like if you watch lead levels over the course of time, we have developed some effective public health interventions around lead. Paint eliminating lead from paint in the United States was certainly a gigantic help with that. But as people started to recognize, like there's this thing and there's this effect, before the regulations went into effect, there probably was a lot of changes that were happening that were a little less risky. But still, I think it's easier to just explain to families that 1978 is kind of your main cutoff time. So it really depends if you're going to ask these questions or deliver them on a screener. That is certainly a viable option in your action plan. And some groups may decide to do that. But you may also just focus on like the first two and like do you live in or spend some time in a place that's before 1978. I think that that's a reasonable approach. Interestingly, gasoline's a little bit different a story. While they deregulated gasoline like around 1980, there was still gasoline that had lead in it, aerosolized into the air, settled into the ground. So living by a freeway does increase your risk of lead being existing in your soil itself. Again, not a like really strong prevalent public health exposure, but a real thing that's happened in the history of our lived and built environment was that even though lead was like outlawed in gasoline, there were still some gasoline supplies that had lead in it into the early 80s.
Thank you for that answer. If anybody else has any other questions, feel free to unmute yourself and ask out loud, or you can put them in the chat and I will read them to Dr. Davidson.
So this session is much more didactic. The sessions that you will have with your practice coach will be much more dynamic, and we're really taking an approach that is the folks that are coming to your practices. They know a little bit more than the general population of physicians around lead, but they're not lead experts. But they're going to be your coach in helping you identify what you really want to focus on and how you're going to employ that over the course of the next couple of months. And we're going to do some monitoring of how you're doing with your screening as it progresses in these months, as you're really kind of focusing in on this topic within your practice. And we hope that the resources that we have built for you, that they're available to you, are helpful. We welcome any of your feedback about what works in this program and what's not working. And certainly if you're feeling stuck or having problems, please elevate that concern or question, and we're happy to help you.
We did get another question in the chat that I think is worthwhile to read out loud. When will we receive books and cards? So your books are actually on their way to you now. Mark, who's been communicating with you, has been also running the book distribution. So he's a busy guy. You will be receiving books in the mail in the coming days. And then we are still working on getting our updated RAC card approved from the Ohio Department of Health. We really wanted to make it more valuable to you all by adding some more information. So those will be coming in the next couple of weeks, definitely by the end of the program, if not way before then. So, and then as an additional benefit to the program, we've also created appointment reminder and education cards. So on it's a short, small postcard, and on one half of the postcard, there's an option for you to circle the next step for the patient, whether they're going to be getting a capillary test, a venous test, they're being referred to early intervention. And then the rest of the card really shows information and education for the patient. So that way they're able to take some time and kind of learn and ruminate on what they've discussed with you in the office and ask questions as they arise. So those are some of the big resources that we'll be sharing with you all in the next couple of weeks. And as Mark said in the chat, he will send information when they're shipped out. And we are right at 1. So thank you all so much for joining. Please go ahead and check your email to claim your CME and MOC credit. We ask that all participants complete the short survey, even if you do not plan to claim credit. This will enable us to collect data to measure the rigor of our programming. Once you complete the survey, you will receive a certificate within 10 days. Mark will follow up with these instructions via email for your reference. Please feel free to reach out to Mark or myself with any questions at all, and we're so happy to have you on this program. Thank you for your time this afternoon and have a great rest of your day.
Bye.